Some drugs may also cause serious problems with the ability of the bone marrow to produce normal cells that are found in the blood, such as white blood cells or red blood cells. The term agranulocytosis literally refers to 0 granulocytes present. Can you name the granulocytes? Granulocytes are white blood cells that have granules, right? These are neutrophils or polymorphonucleocytes, basophils, eosinophils, and mast cells. Basically, agranulocytosis really refers to an absolute neutrophil count below 100, while neutropenia refers to an absolute neutrophil count below 500. This is an important distinction, and people toss these words around a lot incorrectly, so don't get confused. Colchicine is used in the treatment of gout. Here's a microtubule. Now remember, colchicine inhibits microtubule polymerization, so this formation of the microtubules by stacking the segments together. But how does this prevent granulocyte maturation in the bone marrow? Well, all cells need microtubules to complete DNA replication. Any granulocyte that is not properly matured or has not fully completed DNA replication will be destroyed before leaving the bone marrow. Currently, it's not known exactly why clozapine or carbamazepine inhibit granulocyte differentiation, but it's something extremely scary that everyone's worried about, so they just always memorize it. So here in the bottom left, we have metimazole. And here in the top left, we have propylthiouracil. In between the two, we have the structure of a pyrimidine. If you just take a second, you can notice that the picture of this pyrimidine from the biochem book has a lot of similarities with these two antithyroid drugs. Do I want you to memorize these structures? No, but I do want you to know this one. The point that we're trying to get at here is that these antithyroid drugs can prevent granulocyte replication in the bone marrow by interfering with DNA synthesis because they look just like pyrimidines. Similarly, the structure of ganciclovir is incredibly similar to how a purine looks. This similarity to building blocks of DNA is how these drugs can not only inhibit granulocyte lineages, but can also inhibit the growth of all or maturation of all cells in the bone marrow. When all cells are inhibited from maturing properly, we call this aplastic anemia. Aplastic means that the stem cells are unable to form mature cells. If you do a bone marrow biopsy in these patients, you will see that all cells of the bone marrow have been replaced by fat. This includes no platelets, no white blood cells, no red blood cells, and fat on the bone marrow biopsy to actually cause something aplastic anemia. A lot of the drugs that cause agranulocytosis can also lead to aplastic anemia for the same reasons. Some new ones that consider about aplastic anemia are NSAIDs. Everyone uses NSAIDs, a big time drug to know. Everyone in the world is using it at this point. It is not yet understood how NSAIDs can cause bone marrow suppression. But what about benzene? Who is exposed to benzene? Well, it's a result of gasoline combustion, so watch out for anyone that works with engines or an industrial worker. Now, chloramphenicol is used for treating meningitis in severely ill patients that have not responded to the other ones. This is because it can cross the blood-brain barrier very well due to its non-polar benzene ring. That's right, chloramphenicol has a benzene component. So what am I telling you? Am I telling you that chloramphenicol has a benzene ring? Yes. That means it can also cause aplastic anemia just like benzene, because that's the component that it has that's dangerous. How do these cause aplastic anemia? Well, benzene and chloramphenicol both have a benzene ring, and what the benzene ring does is it inhibits topoisomerase 2 and therefore terminates DNA replication. So what's the big deal with chloramphenicol and gray baby syndrome? This is an important thing that you really want to be prepared for just in case you get that question. Chloramphenicol is metabolized by UDP-GT. This is UDP glucuronidase transferase. Remember, babies are born with a lower level of hepatic functioning enzymes. Some enzymes are absolutely deficient in some babies. So some babies just don't have very good functioning UDP-GT. Who is that? How about premature, preemies? They're still working things out, right? Premature newborns are susceptible to accumulating toxic amounts of chloramphenicol in their bodies. This accumulation can actually lead to mitochondrial dysfunction and basically inhibited protein synthesis. If mitochondria are not functioning, babies are going to show signs of hypoxia, right? A great example of this is the blue-gray hue that the babies get in their skin because they're lacking appropriately functioning mitochondria. These are just not working. Now, we talked about hemolytic anemia before, but let's quickly review. Drugs that cause this are classically methyldopa and penicillin. This is an image straight out of your book that shows us this test, Coombs test, right? These drugs, methyldopa and penicillin, somehow trigger production of autoantibodies. You can see here that the patient's blood, if it's covered with autoantibodies due to these drugs, they're going to be coating the red blood cells. When you add an anti-human globulin, which is the reagent, and you see positive agglutination, you can determine that this is a positive Coombs test. Now let's talk about drugs that are associated with hemolysis in the setting of G6PD deficiency. Do you remember what G6PD deficiency is? It is a defect in the enzyme glucose 6-phosphate dehydrogenase that is part of the hexose monophosphate shunt. Now, without any functioning G6P, there will be no way to regenerate NADPH. Without any NADPH, there will be nothing available to help glutathione reductase do its job and restore intracellular levels of reduced glutathione. No reduced glutathione means that there will be no way to neutralize free radicals such as hydrogen peroxide. This is the only way that red blood cells can fight against oxidative stress. A deficiency in the enzyme that regenerates this NADPH leads to the inability of a cell to defend against oxidative stress, and eventually the red blood cell is just going to be like, you know what, I'm going to blow up. We call this hemolysis. Over 300 million people have G6PD deficiency in the world. Remember, this is mostly males, right, because it's X-linked recessive, so it's worth going through a few of the classical vignettes that seem to just pop up over and over again about G6PD deficiency. Now, we look at these drugs and we're like, oh man, we got to memorize all these. But just note one thing. All of these are oxidants. They increase the generation of reactive oxygen and reactive nitrogen species. These things will be neutralized by glutathione. But guess what? These patients have an inability to properly handle this increase in oxidative stress. So some of the classic vignettes. The first vignette usually will go something like this. A Mediterranean or African male, but maybe they were traveling to somewhere in Africa and they needed some primaquine to prevent malaria. Another important one usually involves a hypersensitivity-like reaction that occurs when someone takes a sulfonamide. So these sulfa drugs, they're called sulfonamides because of the moiety that they have within the drug. They're associated with very high yield vignettes because they actually happen in real life. For example, a patient was on Bactrim, which is trimethoprim sulfamethoxazole, or nitrofurantoin for a UTI. Or a patient with pulmonary edema given furosemide, and now they have all these problems related to G6PD deficiency. In other situations, you can have a chronic pain patient that takes a lot of aspirin or ibuprofen, now presenting with hemolytic anemia. Again, watch out for the tuberculosis patient. They love TB. This is classically an immigrant male, remember, because it's X-linked recessive, someone that recently completed isoniazid therapy. This will show up on your exams forever. It's classically tested because a lot of people have it. Another reaction that will always show up on your test is related to heparin. This is heparin-induced thrombocytopenia. Now, what antibody is produced against platelets due to heparin use that leads to autoimmune destruction of platelets? This is platelet factor 4. Now, what originally happens is that platelet factor 4, there's a receptor on your platelet, and here's the receptor, R. Heparin is a highly charged molecule, and sometimes our heparin will draw like this, will go and just stick to this receptor. The immune system will recognize it and start producing immunoglobulins against it. The antibodies bind to the platelet, so now we're going to have our platelet antibodies stuck directly to the platelet factor 4 receptor. And now the platelets are destined for two outcomes. Number one, platelets are going to be destroyed by splenic macrophages, leading to thrombocytopenia or low platelet count. And number two, the antibodies bind the platelet and can actually activate platelets. This is paradoxical in the sense that in the setting of a low platelet count, thrombocytopenia, because of this number 2, where we can actually activate platelets, we're in a setting of low platelet count with an increased risk of thrombosis. So we can form clots despite platelets being low. This is highly tested material because anything that doesn't make sense initially is something that you should always remember. For this reason, if someone ever develops heparin-induced thrombocytopenia, you never give them platelets. You must stop the drug, stop the heparin, and switch to a direct thrombin inhibitor. Can you name a direct thrombin inhibitor? How about argatroban? Okay, now we move on to megaloblastic anemia. Megaloblastic anemia means that the red blood cells have a macrocytic appearance where their MCV, or mean corpuscular volume, is above 100. You can appreciate that here in this image of the macrovalocyte. In the case of these drugs, all of these are due to purely causing folate deficiency. This prevents the formation of thymidylate. If you don't have enough folate, you cannot make enough thymidylate. This is an important nucleotide, TMP, that is required for the building of DNA. Without TMP, the nucleus is unable to mature or finish dividing. Now in a blood smear, you see these huge red blood cells called macro, for big, ovallocytes because they're oval in shape. You also see hypersegmented neutrophils. They have a huge nucleus because it's stuck in DNA replication. Now phenytoin is an important one because we give it to a lot of patients. It actually inhibits the intestinal absorption of folic acid. Methotrexate and sulfa drugs lead to folate deficiency by directly inhibiting enzymes that are required for generating folate that's used in DNA synthesis in humans and bacteria. Can you name the enzymes? In humans, methotrexate inhibits dihydrofolate reductase, while classic sulfa antibiotics like sulfamethoxazole inhibit bacterial dihydroopterate synthase. So again, humans is dihydrofolate reductase, and in bacteria, it is dihydroopterate synthase. These are hard enzymes to remember, highly testable when things are hard. It is important to note that there's some cross-reactivity here, and any drug with a sulfa group in it, or any sulfa drug, can not only inhibit bacterial enzymes, but it can also inhibit human enzymes. It can inhibit with human DNA synthesis. Imagine if you're starting someone's girlfriend or wife on an oral contraceptive, or if your postmenopausal mom is taking estrogen and one of them asks you, what are the risks of these drugs and why? Well, increased levels of estrogen lead to decreased protein C activity. Remember, protein C is a serine protease that cleaves activated factors 5A and 8A. If there are decreased levels of this protein, then your patient is at increased risk of getting a clot. All right, flash quiz, let's do this. Here we go. An 18-month-old boy is brought to the emergency room by his parents. He was found playing with green tablets at his grandparents' house. He's vomiting and alert. Abdominal x-ray shows small radiopaque circles throughout the small bowel. You suspect iron toxicity. What antidote should the ER physician administer to reverse the effects of the chemical that was ingested? This was a nice question because it tipped us initially at what we suspect. We suspect iron toxicity. This is something that is not uncommon because so many people take ferrous sulfate for anemia, particularly older people or moms that recently had a delivery with a lot of blood loss. These ferrous sulfate tablets contain the heavy metal iron, right? They actually show up on radiographs. So that's an interesting little fact. They might include that image on your test day if they decide to trick you or go for something that's a little bit more strange. What we need to do is we need to give the kids something to bind all this iron. What is the chelator you want to give? You want to give deferoxamine, deferasirox, or deferriprone. All are sweet options. Just give them one.